Uh, Good morning, good afternoon, good evening, ladies and gentlemen. It is my pleasure, David Albert, with my co-chair, Dr. Mintu Tarakia, to introduce Dr. Magnus Jensen. Dr. Jensen is the head of the Department of Cardiology at the Copenhagen University Hospital, and he was a founding member of the Danish eHealth Cardiology Group and is a member of the eCardiology Group of the European Society of Cardiology. So he knows of what he will speak. And he's going to talk to us about wearables across the pond and how they view wearables with respect to cardiology and electrocardiography. Dr. Jensen, take it away.
Thank you very much for the introduction, and thank you very much for the invitation. It's a real pleasure. Thank you for a very nice previous presentation, which is of course in the same field. So let me just share my screen here. Go. Okay. So, you know, it's difficult to have a talk about wearables and digital health in this period of time without speaking about COVID. This is way back when, in early 2020, when a conference like this was with physical attention, and people were sitting next to each other, enjoying talks and drinking, enjoying a beverage and so on. And here in the back, you can see a colleague, Jørgen Cantus, also from Copenhagen. So a lot has happened from early 2020 to now. We have had the COVID on the picture on the left. You can see we have the this is I guess a typical image, at least from my institution. This was in the early days when we didn't allow outpatients to the clinic. You can see a patient is being pushed to the intensive ward. Instead of having individuals meeting in the office, we have converted our visits to virtual visits. And what you can see here is one of our consultants with a video camera in front of him. And in the figure to the right, you can see how we have converted during wave 1, Corona wave 1, and Corona wave 2, the two peaks. You can see we are waving off, hopefully, the second wave, that we have converted most of our physical consultations to virtual meets, almost up to 80% of our virtual meets. And that, of course, a triage for some of the patients, and in some instances we can replace the virtual meet with or the physical meet with the virtual consultation. So I have used a title from a Terminator movie. During the COVID crisis, we have really seen a rise of the machines. So not only in the healthcare system, of course, I've done a Google Trend search of telemedicine, video consultation, Zoom, etc. It's the same broader picture. We see, of course, a sharp interest in all things digital. Well, if we move towards the academic sphere, there has really been an increased interest in all things digital. So I'd like to advertise the new journal from the ESC, the European Heart Journal Digital Health. The inaugural version was out 3 months ago. Other institutions have other digital health journals. For instance, the Lancet family and the Nature community has their own digital medicine journal, and there are many others existing and coming up. So, wearables. There are, of course, tons of wearables, as we heard in the previous presentation. We have in-ear wearables, we have body wear, sensors built into textiles of fabric, we have shoes, we have, of course, watches and wristbands. And if we look at the growth of the consumer devices, it's exponential. This is one figure. I could have used many other figures, but it's very clear that there is an increased interest, and of course, technology is abundant. So I don't think there has been a time previously where we have so widespread spread availability of low cost information with high volume physiological data from the community. And of course, that's an untapped resource for prevention, for early detection of disease, etc., etc. So just to give an example of wearables in the current era, this is use of heart rate and sleep data on in the time of COVID. We look at, this is a nice paper by Su et al. If we look at, it's a Chinese a wearable, you see the huge number of individuals that were included in a short time span, around 70,000 individuals from Italy. And what this data show, the authors have developed an anomaly rate index, which is an index of increase in heart rate and longer sleep duration, which is the red one here. And you can see that the anomaly rate increases before there is an detection of increase in COVID cases. Quite interesting. We can also do aggregate data of physiological data or show it in a different way. Here we have on the y-axis we have days since the start of symptoms, and the heart rate and respiratory rate increases before symptoms. I find that quite interesting. So these data are based on Fitbit, and the company or the researchers asked individuals who have a Fitbit and had COVID if they could use their information, and you can get these type of data. And I think it really shows the potential on a population level. So what's the attitude towards use of wearables? Well, we did a survey. The ERA community has done a survey. The young ERA community has done a survey on a European level. And we, in the Danish Society of Cardiology, we've done our own survey. And just let me show you a few key numbers, because I think you all could sort of recognize the attitude. So, for instance, 62% of cardiologists, they had a consultation involving wearables already. And in 42% of the cases, the app wearable led to a further diagnostic workup. Now that's a good thing, but it could be a problem, as we have discussed in the position paper that we recently published. 27% of the respondents said that the app/wearable helped in the diagnosis of that particular problem. And almost half of the cardiologists would recommend patients use an app or a consumer device. So almost all of the respondents, they believed that the use of apps and wearables would increase in the future. And interestingly, a similar amount of people agreed that there was a need for clinical guidance in this area. This is, of course, not, this data is a few months old, but it's a problem that's been around for some time. And that is the exact reason why we published this position paper on wearables in the ESC community. So we have been very fortunate to be able to include a broad collaboration involving major committees within the European community. This is the working group on cardiology, which is basically sort of hosting it. We have involved representatives from ERA, from the Preventive Cardiology Committee, from the Nurses and Allied Professionals community, from the Patient Forum, and from the Digital Health Committee of the ESC, which is sort of a strategic a strategic body within the ESC. So the main purpose of this paper is, well, the purpose number one was to plant a flag and to get some attention to this area, because when we started out in 2018, 2019 to sort of get the political backing to gain some interest within wearables, it was not obvious that 92% of cardiologists would think that wearables had a future in clinical cardiology. That was not the case in 2018, 2019. I mean, it sounds implausible now, but that's how the atmosphere was just a few years ago. But there's been a colossal change in attitude towards this field. So I think that has been the actual main advantage or goal of this paper, was that we sort of said, okay, this is important. We need to focus on this area. Well, I don't know if Armstrong had an Apple Watch. I think he had an Omega Watch, but well, I'm sure that the future astronauts will have some form of physiological wearable on them. I'm very sure of that. So the main figure of the position paper is summarized here, and the layout of this figure is not a coincidence, because you can see there are opportunities in the upper box and there are challenges on the upper box, but they are both pointing in one direction towards implementation into clinical care. And that's the main message of the position paper from the ESC, is we need to move this field into clinical care. As a community, we need to move this into clinical care. So what are some of the opportunities? Well, I think in the previous presentation, many of the opportunities were mentioned, and I completely agree with all of them. Of course, early detection and of risk factors and arrhythmias is a possibility. Then, of course, there is some nudging in it. If you can measure your physiological data, well, that might lead you to a change in lifestyle. You can capture a population level data. You can engage the individual in their own health, and that way that can lead to a shared decision making and a democratization of healthcare, because healthcare is no longer just in the hands of the healthcare provider. It is in the hands of the individual patient. Then, of course, it can be an instrument for public health improvements, and you can monitor population level diseases such as pandemics. So the other part of the position paper and sort of the work within the ESC is also to address some of the challenges, and we don't have the answers in the position paper or in the community right now, but we are asking the questions. We are trying to identify the gaps in knowledge, and I think that's a very, very important task to put on, to identify the areas that you need, that the community needs to focus on. And those are, of course, as mentioned, technical, mentioned in the previous talk, clinical. Well, how should we go about a patient who walks into the doctor, the cardiologist's office, with a measurement from data from a wearable? Low risk patient, that's what we know. We know that these individuals, the users of wearables at this point in time, low risk individuals who are interested in fitness. Well, is that the target population that we need? Usually we are interested in identifying high risk individuals. So how do we move the data information from the low risk population to a high risk population? If we, is there a risk of overtreatment, overuse of healthcare services? If we act on every little information from a wearable, don't we risk to overdiagnose, to make echoes, to do angiograms, and maybe even cause harm at some stage, and certainly it will cost money. Then there is a social factor. Who are users of wearables? Well, people with resources, because consumer devices are expensive, or expensive to many people. So there is a social inequality in it. And then there is something that I find extremely interesting. That's what are events of interest? We are used to, as cardiologists, we are used to looking at something, we are trying to predict something that is happening 10 years in the future. So you have a high blood pressure, well, we need to lower it so you don't have a stroke or a heart attack in 10 years. But now, with continuous physiological measurement, why wait 10 years? Why not intervene very early in the causal pathway of cardiovascular disease? I find that very interesting. And then there are, of course, privacy issues. And then there is something that also needs to be discussed, and that's unintended health behavioral change. The fact that some people that have continuous medical or the physiological monitoring, they have an unhealthy attention towards their data. So these things are some of the things that we have addressed in our position. We have discussed in the position paper, but we don't have the answers. But our main goal as a community, across our communities in all continents, I would say, is to move the field from gadgetology to clinical cardiology. Thank you. I will stop the sharing now.
Thank you, Magnus. That was great. We already have a question. And he was asking, could you please show the slide with the anomaly index again and comment why you think this is possible? What was the forecast? And I bring up the notion of prediction is usually very hard unless you're, I can tell you the sun will rise in the east tomorrow. So I'd love to hear your comment about the anomaly index.
Well, I might not be able to answer that question. Let me go back here, see if I can find it. Just a second. The anomaly index. Here we go. Let me share my screen again.
Thank you.
So now I can see this. So what was the question again?
Well, the question is, why do you think this is? Why do you think there is this preceding change in physiology before the manifestation of the actual disease, in this case, COVID?
Well, I think because, of course, there is a delay between a virus or infection and then individuals being registered as having COVID. You're registered when you have a positive test or when you are admitted to the hospital. So these data show, or at least I think these data show, that the physiological changes, they come before admission, and I think that's plausible, isn't it?
Absolutely, absolutely. Another question is, and you brought this up, is that there is going to be differences between different parts of the world, between different levels of affluence in terms of the adoption of digital health technologies and wearables. And, what's that going to mean for people? The world is unfortunately not going to be equal.
I think of course, there's a global perspective on this, but I think we also have to look within our own jurisdiction. So there are social disparities in all our societies, and I think we as doctors, we need to make sure that healthcare is available, and I think I think this is a positive, right? Because in time, physiological data, a wearable will be cheap. It will be cheap technology. It will be built in a T-shirt, right? So I think in very few years, 4 years, 5 years, 10 years, this will be accessible information for everybody. But till then, we need to, of course, address that there are social inequalities.
Yeah, Dr. Tarakia, I mean, you run the Center for Digital Health at Stanford. Dr. Jensen, do you think our perspective here versus there is any different in terms of the everyone having access?
Are you asking me, Dave, or are you asking?
Yes, sir. I'm asking. Yes, Mintu.
Yeah. So I think it's changing here. I think that much of the work that we're doing now is really focusing on vulnerable population. Now, that's very easy to say because there's always going to be grant money and foundation money for that, right? So we have a number of projects targeting inner city populations, Black, Latino, or Latinx populations. In some really urban areas where literacy rates vary, poverty level, the 42% of people are below the poverty line in Camden, New Jersey. We're also starting to target gig economy workers because around here, in the way that healthcare is structured in the U.S., they may have marginal access to healthcare. So all of these things are happening, but again, they're happening because there's philanthropic and academic support. Ultimately, universities, in my opinion, can't run products. And so to get them to scale and to have a balance or a model where people can afford this, or that the payers or the government can pay for it, or there's some social capital where everyone's bought into it. I mean, if in some ways, health insurance should be a way it's a way of pooling risk, but maybe it's a way of pooling technologies across those who can't afford it. We haven't really solved those hard questions in the US yet.
Thank you. Magnus, I got a question for you. Do you think it will be the Philips and Medtronics and Biotronics, or the Apples and Googles who bring this, make it more ubiquitous?
It will probably be the technology that's closest to or closer to the consumer. I think that's the answer. And whatever the name of that company is, I don't know if it's Apple, Google, or Philips, but I think that's the answer. The closer you get to the consumer, the more likely it is to be affecting that person's health. So let me just I know we are running out of time, but you had a question in the previous session about implementation of wearables in Epic. We too have Epic in Denmark, and we are starting to run projects where we are integrating data from wearables into Epic, and that's a huge step. And that is a huge step because that makes it scalable. So that's extremely interesting, and that opens the door. That truly opens the door for telemonitoring, for having individuals with atrial fibrillation monitored at home, but being consulted by a doctor at the hospital and so on. So that's very, very interesting, and I think that might lead that might be a key factor in leading the change towards more telemedicine in modern medicine.
Magnus, I have a question. That was a great talk. The question I have for you is there any sort of professional society or greater lobbying to fix GDPR as it relates to the delivery of healthcare and research?
There are works on the way, and I don't know if the position paper has been published, but the ESC and members of the working group of Cardiology has participated in a big European statement specifically on this. So it's within the EU. When I say European, I mean the EU. It's the EU framework. So I mean, this is something, of course, that needs to be focused on. Very important.
That's great to hear. Thank you.
Yeah, it is. Well, Magnus, thank you very much for an outstanding talk. And I want to thank my co-chair, Dr. Tarakia from Stanford. And I hope everybody here at ESC has enjoyed these two presentations this morning. And I think we all take away from it that wearables are here to stay and that they are going to help us, but that there's a lot of work to make sure they help and not hinder the care of patients. So I want to thank all of the participants today, and hopefully some of you come back as I'm about to give a talk later. Thank you very much, Magnus. Thank you, Mintu.
Thank you. Thank you.
Thank
Bye-bye.
you.